Welcome back, everybody. Thanks so much for joining us. And good afternoon. This is our third and final panel of our first CHW Innovations Summit. My name is Amy Freeman, and I'm a research assistant professor in the Department of Population Health at NYU School of Medicine. And along with my colleagues, Nadia Islam, Sana Lim, and Sue Kaplan, I co-lead NYU's Community Health Worker Research and Resource Center. I am so pleased to introduce our moderator today and fellow Brooklynite, Marjorie Momplaisir-Ellis, who will be moderating our panel on public systems leading the way, CHW initiatives at the nexus of public health and health systems. Marjorie is Senior Director for Housing Engagement and Collaborations at NYC Health+Hospitals, Office of Facilities Development, in the newly formed Housing and Real Estate Unit. This unit focuses on housing solutions for homeless and housing insecure patients. Prior to joining the Office of Facilities Development, Marjorie worked at One City Health, which is the New York City Health and Hospitals sponsored Performing Provider System, or PPS, which was formed as part of the New York State's Medicaid Redesign Program, or DSRIP. Before joining One City Health in 2015, she provided 14 years of dedicated service at CAMBA, one of Brooklyn's largest social service providers, where she directed the Greater Brooklyn Health Coalition and operated several maternal and child health home visiting programs facilitated by community health workers. So thank you again so much for being with us here today, and take it away, Marjorie.
Thank you so much, Amy. It is my honor and pleasure to be with all of you and to be part of the inaugural CHW panel discussion this afternoon. First, I would like to remind everyone of a couple of housekeeping rules. Please type in your questions into the Q&A box. We will collect them and save them for Q&A portion of the panel. And then at the end of the discussion, at the end of the session, there will be a pop-up with a few questions regarding this session. You'll also be receiving a slightly longer evaluation of the CHW Innovations Summit in your email. Your feedback will be very valuable to us as we plan future summits. You are all in for a treat this afternoon to be part of this conversation with Maia, Jenna, and Sarah. I will read to you some brief bios followed by the panelists' brief presentation so that we can get into a really rich conversation. First, let me introduce Maia Ingram. Maia Ingram is the co-director of the Arizona Prevention Research Center at the University of Arizona College of Public Health. For over 20 years, Ms. Ingram has partnered with community health workers and health centers and grassroots agencies in rural, urban, and U.S.-Mexico border communities to develop and evaluate CHW programs addressing health promotion, chronic disease management, mental health, hearing loss, and environmental health. Ms. Ingram is interested in efforts to promote the sustainability and compensation of the CHW workforce and collaborated closely with the Arizona CHW Association and CHW stakeholders to pass CHW voluntary certification in 2018. So welcome, Maia. Our other speaker on this panel today is Jenna Lupi. Jenna is the Assistant Director of Primary Care Transformation in the Office of Population Health at New York City Health+Hospitals. She serves as the Program Manager for the Office of Population Health Community Health Worker Initiative, focused on re-engaging patients in primary care and solving for SDOH needs. Previously, Jenna served as the Care Delivery Reform Specialist in the state of Connecticut's Office of Health Strategy, where she advocated for CHW certification and CHW integration into primary care statewide. She completed her MPH at Emory University Rollins School of Public Health. Sarah Flammang is our final speaker as part of this panel. Sarah is Vice President of Operations and Administration at Baltimore Corps, a nonprofit that enlists talent to accelerate social innovation in Baltimore and advance a citywide agenda for equity and racial justice. Sarah has held several different roles during her 6 years working with Baltimore Corps, but has focused on forming partnerships with impact-oriented organizations, agencies, and entrepreneurs. Most recently, she has led the organization's COVID-19 response initiatives, including the Baltimore Health Corps. Baltimore Health Corps is a large-scale initiative to train and employ over 300 people, many as community health workers, doing contact tracing and care coordination in Baltimore. So we have a fabulous panel this afternoon, and they are delighted to be with you. I will turn it over to our first speaker, please.
Thank you very much. Well, thanks for the introduction, Marjorie, and I'm super pleased to be part of this panel. I've enjoyed the conference very much and the conversation. I feel a little bit like I'm from the other part of the country because you all are having lunch and I'm just getting there, but maybe there's some other folks in the panelists. I know I saw Carl Rush and I think he's in Texas, so he and I still have some lunch to have. But so I know we just are doing some brief presentations and then getting into some good conversation, but I want to cover 3 areas in my conversation, my 10 minutes that I have. And the first is to talk a little bit about the history of the Arizona Prevention Research Center and what we are, to give you some context. And the other is to talk about our community clinical linkage model, which is sort of to address the topic of this panel session about integrating care into health and clinical settings. And then the third is to talk a little bit about our efforts with voluntary certification and how we've integrated that to think about sustainability. So the Arizona Prevention Research Center actually has been funded since 1998, and it's funded by the Centers for Disease Control. But our roots go back much further than that. And I always have to take my hats off to my colleagues and mentors and friends, Jill DeSapien and Joel Meister, who in the 1980s went to Yuma County, which is a farm worker community, and with the community there developed a maternal and child health model, a home visiting model called Comienzo Sano, or Health Start. And they worked with a woman named Emma Torres, who was a farm worker and then became a promotora de salud and really has gone on to champion the workforce and farm workers nationally. And that model, the important thing, and the reason that I bring it up, is that it is the one sustained community health worker program in the state of Arizona. The program is actually a line item in the Arizona budget, which is incredible and probably cannot be replicated. So the fact that that money goes through county health departments to pay for maternal and child health services. Since that time, the Prevention Research Center has worked with community health workers and their organizations to look at to develop and evaluate different programs and develop an evidence base for Arizona in different areas. So since that time, as you can see, we have a tag model that really focuses on community health worker effectiveness in Arizona and beyond. Next slide, please. So to talk a little bit about the model, the innovative model that I wanted to share with you, this is a community clinical linkage partnership. And I know that we heard a lot about that just in the last session, how many healthcare plans are working with community-based organizations to address these issues. And our model is similar to that. This was developed with the partners that you see over on the side, county health departments and federally qualified health centers. And the idea for us was to create a community clinical linkage model in which there were CHWs in community settings and CHWs in clinical settings that collaborated together. When we did our literature review on CCLs, or community clinical linkage models, what we noticed is that there was often a CHW in one of those places, but not in both. And there's been a lot of discussion about the fact that there's a lot of similarities, but there's also differences in the context of those work environments, obviously. And to allow each CHW to work at the top of her game within those contexts really meant that having one in each site that then worked together might yield a different kind of a collaboration. So that's one thing that we felt was really important about our model. The other thing is that we, with links, linking individual needs to clinical and community services, we did not focus on a disease state. Rather, we looked, the CHW met, the idea was to provide a CHW who met with the participant on a regular basis to talk about whatever the participant wanted to talk about and connect her to these community services, he or her, to the community services that they determined were important. So that was obviously a lot of social and determinant of health services, but also a lot of social support and listening and providing emotional and tangible support to those clients. So I'm super excited to show you this slide because it is the unveiling of our replication guide. That's an online guide at our website that you can access. And each of these tabs will send you to resources that you can use to develop programs and adapt it to your specific context. So the first one is to sort of think about creating a partnership and who are the right partners to work on that. Number two, looking at the population that you want to work with or the community and what kind of resources are available to you. We have a lot on thinking about hiring and training CHWs, but also creating an environment for CHWs in which they can thrive. Then I think a key component of our model, which is quite innovative, is communication. So CHWs in community settings obviously don't have access to clinical data. However, we used REDCap to create a communication tool so that they could share confidential information about a client and get them into both the clinical and community services that they needed. And then the implementation and evaluation tabs sort of give you more input about what the CHWs did and some of the evaluation outcomes that we've experienced. So I think the sense to which this is a community health worker to community health worker model and the extent to which participants drive their needs and the responses to their needs, I think are a very important aspect, as well as the fact that it highlights the importance of the strengths of a community health worker in community settings versus clinical settings. Because like I think as we've moved forward towards thinking about how can we pay for community health workers, they've often been, that's often been within clinical settings, which is quite limiting to what CHWs are able to do, as we know. So my last slide, please. So with my last slide, I wanted to talk a little bit more about the issue of sustainability, because our study that you saw before with Links was a practice-based study. So we did this with our community partners, and that's very intentional. Number one, because we couldn't create it without them, but also that we're creating interventions that take into account the context, but that also builds institutional support. So once those organizations start working on this, they don't necessarily want to let programs go. That's especially been our experience with county health departments, fortunately. Once they see the value of the program, they don't want to let it go. But that's not a sustainability solution. And whenever you ask about sustainability, and even though the models we heard this morning had some great reimbursement approaches there, we're still all struggling with, well, I hope we're going to get the next grant. So in Arizona, as was mentioned in my introduction, we took the approach of thinking about voluntary certification with an aim to getting reimbursement. And that was a tough decision. And I know that each state has to wrestle with whether or not that's the right approach for us. But I think that one thing that I might offer from our perspective is that we're really thinking about the workforce driving their own process of their careers and of promotion. So the idea of being certified means that you're not tied to a job title in an organization, but rather you're an individual and you have a number of different jobs through your career, and you move into different positions within those jobs, and you may become a supervisor, but you've been certified as a community health worker, and that's a label that you carry with you, or a recognition. And then if you decide, if you, I forgot the other part that I was going to say. So that's an important part of thinking about why we took this approach. So the left side I just wanted to show you was the Arizona Community Health Workers. That's the professional organization for Arizona, which led the charge for certification in Arizona. And this is how they talked about community health workers with healthcare organizations and legislators and stakeholders. And then on the right is my friend Flor de Redondo doing a testimony in front of the health committee at the legislature. And there's a group of us standing in front of the House of Representatives. And we also worked very closely with community health representatives representing tribal nations, so that we very much made sure that as we moved forward, we had a unified workforce in addressing and in using this approach to address sustainability. So as we move forward, we are only in the process still of making rules, but we're having to do that very carefully, and we're doing it under the guidance of a advisory board that is majority CHW, and that is relying upon the Arizona Community Health Worker Association, led by Flor, to really make sure that CHWs are in charge of that process, including the training And then we've also had very optimistic conversations with the Arizona Healthcare Cost Containment System, which is the provider of Medicaid. They are the administrator of Medicaid in the state of Arizona. And they're very interested in reimbursement for CHW services. And so we are optimistic moving forward that we will have some specific ways to bill directly for community health workers within those organizations, and again, understanding that that can be problematic in terms of who is a community health worker and making sure that the right people are certified. On the other hand, it means that every community health worker comes into a healthcare setting, and I listening to those wonderful community health workers and how they demonstrated to providers that they were of value. In some sense, they shouldn't have to do that. They come in with their professional recognition and their certification, and a certification will hopefully help them be recognized within that context. And they're also bringing their own funding stream. So my hope is that it builds their own independence and recognition for themselves and their ability to promote themselves in an organization and as they move from one organization to another. I'm also really excited about the fact that Access has interest in possibly reimbursing community organizations for social determinant of health services. So that's down the road, but that would basically fund our links model, right? Because the CHW in the community could get funded and the CHW in the clinic could get funded. So we're taking the long view in terms of sustaining our efforts. So I look forward to hearing questions and ideas from the folks in the audience and also the presentations of the other panelists. And thanks for putting my link in there.
Thanks for Maia. Sarah will present next, please.
Great. Thanks, Marjorie, and thanks for that wonderful presentation, Maia. My name is Sarah Flammang. I'm the Vice President of Operations and Administration at Baltimore Corps. As Marjorie mentioned, we're a nonprofit in Baltimore, and we focus on connecting talent to opportunity. And so for us, that's connecting talented individuals to resources, job opportunities, networks, and professional development. And we do all of our work with an emphasis on equity and racial justice. So I'm excited to tell you a bit more about our recent work with the Baltimore Health Corps and how it intersects with the community health worker work that we're here today to talk more about. So the Health Corps is a large initiative that started about 6 months ago in response to the pandemic. We are working closely with Baltimore City government, community-based organizations, as well as philanthropy and other organizations locally and nationally. Our organization is leading the recruitment and screening efforts for the hiring process for the Baltimore Health Corps. And in particular, we're hiring more than 300 people, and most of those are community health workers, which you can see why that brings me here to talk with you today. And so the effort was really started with the goal of not only focusing on the needs of the pandemic and the public health response, but also on the economic challenges that individuals are facing throughout this time. And so as a result, we look to hire individuals that are closest to the problem because we believe they're also closest to the solution. And so that is really the basis of why we selected community health workers as part of a foundation of this model. We really wanted to employ people from the most vulnerable populations and ensure that they would be able to connect and build trust with people when they were reaching out to contact them about contact tracing and care coordination efforts. And so we also wanted to ensure that these jobs were really accessible for people and didn't require a background in public health or prior public health experience, because we also recognize that the economic impact on people really spans the gamut, and you know, people who didn't necessarily need to have public health experience to do this work. So our progress so far, we've received a large number of applications for these roles, more than 7,000 applications. A majority of the staff have been hired, although the work does continue. So if you know of anyone that's looking to work in this field in Baltimore, please send them our way. And next slide, please. So as I mentioned, we recognize that the pandemic as well as the economic crisis really impacts disproportionate impacts on individuals. And in Baltimore, our population is majority African American. And so in our work with the Baltimore Health Corps, we wanted to make sure that the people we're employing are reflective of Baltimore's population and communities in order to, as I mentioned, really build trust and increase the effectiveness of the contact tracing and care coordination efforts. And so this is a snapshot from our COVID-19 dashboard for Baltimore. And you can see the disproportionate impacts here. Next slide, please. So a little bit more about what the model looks like. As I mentioned, Baltimore Corps is really leading on the recruitment and screening efforts for these positions. Our efforts were really based in the foundation of ensuring that equity was present in each stage of this initiative. And for recruitment, that meant making sure to take out as many credentials and education requirements as possible. And like I said, we don't expect that everyone needs to have extensive background in public health or have prior experience there. So some of the applicants that we've gotten are Uber drivers, or they worked at a restaurant, or some other prior experience with customer service that would prepare them well for these positions. Another piece of the model is that we're really looking to the long-term career opportunities for the individuals that are employed through the Baltimore Health Corps. And so when we think about sustainability for the Baltimore Health Corps, this isn't necessarily continuing to employ people as community health workers, but to really use those skills and allow them to apply what they've learned and their certification in related positions, maybe within the public health field, maybe outside of the public health field. And so the supports that we put into place are really around helping them to navigate those future career decisions and growth after the health corps is over. So that includes things like career planning, legal and mental health support, financial coaching, and other pieces that will help them overcome any barriers that they might be facing towards employment. And then the other piece that's important about the model is that we are providing up to 100 people with CHW certification. So those might be people that applied and didn't have as strong of an application, or those that applied and did but wanted some additional training. And so we hope that that additional certification will also strengthen their long-term career opportunities and growth as well. Next slide, please. And then just a little bit more on sustainability. So the foundation of this model was really thinking long-term about the individuals in the program and how we could set them up for success afterwards. We are learning as we go. We've incorporated a lot along the way, and we don't have exact outcomes yet to tell you about, but we're excited to kind of continue learning and hopefully report back soon about some of those long-term goals. And so I think with that, that's all I have to share right now, but I'm excited to continue the conversation with everyone in a few minutes.
Great, thank you so much, Maia. Jenna, if you could go ahead and get started for us, thank you.
Great, thanks so much, Marjorie. So excited to be here today. It was great to hear from Maia and Sarah as well. My name is Jenna Lupi. I'm the Assistant Director for Primary Care Transformation in the Office of Population Health at NYC Health+Hospitals. For those who don't know, NYC Health+Hospitals is the largest public health system in the country. We have 11 acute care facilities and dozens of additional clinics throughout the 5 boroughs. So I'm here today to talk about our community health worker program, which we launched last year. Next slide, please. So we launched a community health worker program, which is based, for those who are familiar with it, on the University of Pennsylvania's impact model. Our program goals, our biggest goal is really to assist our clinical partners in caring for high-risk patients by reducing hospital and emergency department use. And we see our two main mechanisms for that as one, improving primary care engagement for our patients. So that is ensuring that they have appointments, ensuring that they get to appointments, and that they understand what's happening once they get there and the follow-up. And then our second mechanism is to address social determinant needs for our patients, including things like food, housing, transportation, a whole range of other items, which I'll talk about in a little while. And then our secondary goals, we do focus on patients that have chronic disease. So to the extent that's possible within our initiative, we do focus on chronic disease control. We also, of course, seek to improve our patient experience and help them to achieve goals that they determine. Next slide, please. So just a little bit about our program staff. So our medical director is Dr. Alessandra Calvo-Friedman. Previously was Dr. Janine Knudsen, who is actually the individual who started this program. And then our amazing CHW supervisor, Evelyn Perdomo. And then we have 3 community health workers at 2 of our acute care facilities. So at Elmer's Hospital, we have Maria, Nicole, and Cezita. And at Queens Hospital, we have Keisha, Tenzin, and Ronnie. And this is our original team that we started out with last July, and we still have our whole program staff together, which is very exciting. Next slide, please. So a little bit about the patients that we work with. So we focus on patients that were admitted to the hospital or discharged from the emergency department within the last 24 hours. The patients that we identify within those include patients that we consider medium to high risk for utilizing the ED or inpatient. And this is based on a risk score that our hospital system has developed. And it really is based on past utilization as well as a whole number of social determinant predictors. Patients that we work with also have, as I mentioned, at least one chronic condition, have not been very engaged in primary care. And then we have a few exclusion criteria that really just help us focus in on those patients that we think we can best assist through this intervention. Next slide, please. So just a little bit about the patients that we serve. So as you can see here, this is based on the patients we were working with through the end of January of this year. And we do have a large segment of English-speaking patients, but also a large segment of Spanish-speaking patients and Bengali and Hindi. This is based on the languages that our CHWs speak. So at Health at Hospitals, we have a whole range of languages that our patients speak, but we, of course, could only hire 6 CHWs, so we had to focus in a little bit. And then to get an idea of the sort of income status and socioeconomic status of our patients, you can see that more than half of our patients have some kind of Medicaid. In fact, a large portion of those are emergency Medicaid, so really not insured. We only have a very small segment of patients with commercial insurance and a little bit of a chunk of Medicare. So generally speaking, our patients are pretty low income, low socioeconomic status. Next slide, please. And just briefly, what do our CHWs do with their patients? So this is a 3-month intervention, and it's really focused on meeting the patient, getting to know them, and identifying goals that they feel will best support their health and well-being. The CHWs will help with discharge. They conduct a home visit, and they connect patients with community resources. So that might mean going to a food pantry with a patient, going to the Social Security office, whatever needs to be done in order to help the patient meet the goals that they've identified. As I mentioned, connecting to primary care is a huge part of our program. So one of the big steps the CHWs also do is make sure to get that appointment scheduled. They often go with the patient at least to their first primary care visit to make sure the patient's getting the most out of that visit that they can. And then as the intervention winds down, our CHWs will focus on helping the patient identify a long-term support, whether that be a person in their life or another program It really depends on the specific needs of the patient. Next slide, please. And just to give an idea, I spoke to this a little bit in the beginning, but this is just a brief snapshot of some of the what we call roadmaps, which are really patient-identified goals that our patients identify and that our CHWs help solve for. So you can see it runs a gamut. We do focus a lot on appointment support first and foremost, but then we do a lot of work in food security, medication assistance, insurance, legal, as a lot of our patients are have various immigration statuses, and things like transportation come up a lot as well. Next slide, please. So just a few key points about our program. From funding standpoint, our program is baked into our operational budget. It is not grant funded, so we're very lucky in that regard. And we're very interested in expanding this program over time. So that's something we're working very hard on to identify return on investment for this initiative so that our system can commit even more funding for the program. Our CHWs generally work with about 20 patients at a time, so it's a rotating enrollment. We do document in our electronic health record, which means that all of our providers can see the notes that our CHWs have on their patients, and vice versa. Our CHWs are able to see anything that's going on with the patient medically. As I mentioned, handoffs are a big part of our program to make sure that the work we do with our patients in those 3 months continues on. So we do focus a lot on ensuring the patient has the right supports when we complete the intervention. We meet, our supervisor Evelyn meets with each CHW every week to review cases. So it's a very close relationship that we have to ensure that our CHWs are well supported and that especially challenging patient cases are solved for. And we also have a weekly case conference where we discuss cases and we conduct ongoing training with our team. And then lastly, transparency is a big part of our program. So we do share semi-weekly and monthly metrics with our care teams at our facilities to ensure that they're aware of the progress of the program and also to get feedback from them on ways we can improve. Next slide. So just to wrap up, a few areas for improvement that are top of mind for us right now. So one is moving beyond social needs. We really want to focus on lifestyle changes and help our patients that are trying to manage multiple chronic conditions. And especially with the introduction of COVID, that has really made it even more difficult for our patients to do things like get exercise and get access to healthy food. So we do want to shift away, not away, but to be able to focus more on lifestyle change. And so we're thinking through some ways we can balance those different needs our patients have. The second is integrating our community health workers more into clinic. So I heard, Maia talk about the sort of clinic and clinical community linkages, which is huge. But even within the clinical setting, it can be difficult for our community health workers to connect with other members of the care team. And even more so during COVID, when care team members are more remote, it has become even more challenging. So that's something that's top of mind for us. And then lastly, aligning with other programs, also similar to the community clinical challenge, connecting with programs that are in the community, but also connecting with programs across our rather large system and making sure that we're aligning as much as possible, supporting our care team members and reducing redundancy. And all of this, of course, in the context of on return on investment and long-term funding as well. So yeah, I think that's all I had. So thank you so much and looking forward to getting into the discussion.
Thank you so very much, Jenna. Thank you all three panelists. You've given us wonderful context and overview of the programs that you operate. I just lost all internet video connection, so I am only on the phone, so I'm not able to see the Q&A as they come in. So I'll ask my colleagues to be able to ask the questions that our audience is typing into the Q&A when we get to that portion of our panel. Right now, I get moderator's choice. I get to ask some of the questions that have been percolating in my mind as I listened to the three of you really talk about your specific program model, and just wondered, how did you determine that a CHW model was best suited to address the issues that your program focuses on? So I want to start with Maia. And Maia, I love the idea that you talked about CHWs as a professional, just as we think that a nurse is a person who has various roles and has different jobs, that it's not just, oh, for this one initiative, for this one program, we want you to focus only on diabetes, but that this person, that we should be examining it as a workforce where people are able to get different professional jobs. But wondered about your thinking around the CHW model. How did you first decide that they would be the best people to take on the challenges of the communities in Arizona? And how do you think CHWs are well suited to advance racial and health equity? So I'll ask the same question of all three panelists, but if we can start with Maia first, that would be great. Thank you.
Well, thanks for the question. What I didn't necessarily say in presenting the model is, since CHWs are part of our community action board, we're sort of starting from the place of the assumption that community health workers are going to be at the provide the basis for the interventions that we develop together. However, I would say that we were thinking as a community action board about what we wanted to work on. Behavioral health was a major issue in many of these border communities. And I think that one of the questions was about whether or not any of these took place in a rural community. And in fact, behavioral health in rural communities is difficult to access. That's changed somewhat in recent years with the integration of primary and behavioral health care, but it's still difficult to access culturally competent care. And some of the work that we've done on other projects had identified the facts that even when they would say something to their primary care provider, then they would get a phone number. And if they did make the call, then the person would answer in English. And that was pretty much the end of a behavioral health link up. Or they went to an appointment and had an exchange, but that they weren't getting the kind of cultural care that they needed. So it wasn't about replacing behavioral health care, but it was sort of recognizing that there's these barriers and feeling like it had not been well documented how community health workers address emotional wellness among community members. And so having brought up that issue, our focus was emotional wellness and really filling the gap in our understanding about the role of community health workers in helping people feel supported, that they have somewhere to turn, that they know how to access the resources they need, and measuring outcomes in emotional health. And that's what we looked at. And we also looked at health data, but that was the crux of our investigation, was to think about emotional health. And that came from our border partners over a number of years. Behavioral health and access has been an ongoing issue, and the levels of depression and of course have only risen in recent years. And in terms of addressing racial inequity, I mean, it's such an important topic of the time. And I think we all need to be investigating how we address those issues beyond the statements that we're making, really take apart how we're thinking about problems and coming up with solutions. But I would say that it's not just that community health workers prioritize the needs of communities of color, but that they do community level advocacy when they're provided with the opportunity and the space. And that means identifying the inequities that exist and challenging systemic oppression and institutional discrimination. And I think the more that we give them the space to speak up and understand that their recognition of those issues is far greater than ours with our lens, I think the more that they will be able to address those issues, which is one of my greatest concerns about just reimbursing through clinical and having it all be about getting that reimbursement, because then we miss the role of the CHW in the community setting, the great presentation we heard this morning, and how they know those inequities that occur on the ground and can address those. So that's like a whole other panel that we could get a whole other level of experts that I think I would love to hear from. But thanks for the question.
Thank you. Wow, the CHW as the advocate, as a change maker, I love it. Sarah, would you answer the similar question about how CHWs were chosen as a model to address the issues that your program focuses on, and then how CHWs are well suited to advance racial and health equity?
Sure. So for us, it was really about taking this moment of the pandemic and the public health crisis, the economic crisis, the racial injustice that's going on around us, and this moment to really evolve and change the public health space. And in particular, there's a large emphasis on education within the public health sector. And so we wanted to kind of walk that back and see, like, is that really necessary for these positions? You know, our answer was no, that what it really takes is empathy and caring about people. And so the community health worker model really aligned with those goals, as well as really a focus on equity and racial justice within our program. As I mentioned before, it was also about really building skills for the community health workers to be able to take what they learn in these temporary roles and build their future career. And hopefully some of them will stay within the public health space and continue to bring their community expertise and knowledge to the public health world. And then finally, it was also about really being effective in the pandemic and using the trust and relationships within the community to more effectively execute on contact tracing and care coordination, and really bringing their expertise in that area to the work. And then in terms of equity and racial justice, you know, it's steeped within everything that we do. So from the beginning of the planning of the project, you know, we looked at it at each stage of the effort, the onboarding of new employees, the training, the day-to-day operations of the work, recruitment, of course. And so, you know, it was very important to us at each phase.
Thank you so much. Jenna, tell us more about how CHWs were chosen as the appropriate workforce to do the work in your program, and then how they address social equity and racial disparities.
Yeah, absolutely. Thanks, Marjorie. So the particular model that we chose was really because of the strong evidence base. So we, as I mentioned earlier, modeled our program off of the University of Pennsylvania's impact model. So the idea of having community health workers wasn't necessarily new to health and hospitals, but the particular approach was. And that really, the idea being that we could adapt a model that would be potentially have a strong return on investment, so that we didn't have to go from grant to grant, because we have so many grant funded programs at the hospital. And the idea of not having it be grant based, so baking it into our operational budget, was kind of a new idea. And so that was really, I think, really innovative for us, and continues to be. I think it surprises people every time they ask how our program is funded to know that it's not grant funded and that it's not going anywhere. And in terms of addressing racial social disparities, you know, again, I point to the impact model because the way that we hired our community health workers, actually also Sarah, something you said about the way you looked for your workforce is very complementary to what impact promotes, which is that the CHWs we hired did not necessarily have a health background or any kind of background that would necessarily make you think healthcare facility. And that was very strategic. And I think it has made all the difference in our ability to address our patients' unique social needs, because the individuals we hired really truly are from the community, and not just like from the community, like they happen to have a zip code there, but really understand the community, the background of the patients that we're working with, and are able to make progress with them really quickly because they've been through those experiences themselves, which is really what, you know, the traditional community health worker was all about. but can sometimes be lost, especially through grant-funded programs that sort of can change the intent of the program. So that's really the thinking behind this particular model at Health and Hospitals.
Thank you, Jenna. Because you mentioned, Jenny, sorry, because you mentioned not being grant funded a couple of times during the conversation, I wondered if you could talk to us about how did your office get to the place where you have support internally? What was the process like to be able to get to a place where it is funded by Health and Hospitals? And any lessons that you'd like to share that you learned from this process. Then I would love to hear from Maia about being a line item in a state budget. Wow, that's what we want to be when we grow up. But I'll let you speak first about getting the internal stakeholder push to be able to have internal funding, Jenna.
Sure. And I wish I had a magical solution to this, but all I can say is that it really comes down to leadership belief in the program. And for us, it really truly was that our director believed strongly in the impact model and felt that our system had, as I sort of alluded to before, our system is no stranger to community health worker programs. So it wasn't that was the innovation necessarily. It was this particular model that had demonstrated real financial savings for the system in Pennsylvania. And this belief that in our office, which is in our system is the Office of Population Health, which is very focused on these types of solutions, it was sort of time for us to take this on and really bake it into our overall programming. And so the reason I say I wish it was a magical answer, I mean, you really have to have that sort of leadership support in order to make that decision, because as we know, you're not always going to get the perfect numbers that you're looking for when you're doing these analyses to find the return on investment. That's not to say that we all don't know that the value is there. We see it in our patients every day. We know the benefit, but it is difficult to show those numbers. So having that leadership support is so critical. And then I think, Marjorie, you asked me about lessons that we learned. Lessons that we learned specifically related to the funding issue, I would say that even with the leadership support, at some point you're still gonna need to demonstrate the financials. And so that's what we're working on right now, is really digging into a more detailed analysis of the data to demonstrate the financials. And we hope, and we believe, but also hope that we'll be able to demonstrate that so that we can expand across the system.
Thank you so much, Jenna. Maia, can you talk us through your funding sustainability process? How did you get to where you are now? What does the road ahead look like? And any lessons learned that you'd like to be able to share with us in different states about the best way to go about making this workforce far more sustainable?
Yeah, you know, the Health Start program is kind of a miracle, and it was passed at a time things have changed in terms of the Arizona legislature. I think it created an evidence base, so they were able to advocate in the legislature for this specific program, and they did connect it and continue to connect it to ROI. So I think it's not as difficult when you show birth outcomes and the cost of different birth outcomes. It was a pretty easy argument in terms of home visiting. But it was somewhat before my time. I came to the PRC after that program had already been institutionalized within the county health departments. But that said, you know, the county health departments hire community health workers at the bottom of the totem pole. So someone who is a forward-thinking person, I mean, all community, I shouldn't say that, but community health workers, they don't want to leave their community. They want to continue to do the kind of work that they're doing. And so in order for them to be promoted, they have to move into a different kind of position, which means that basically community health workers across the state are in the lowest paid positions in all of these health organizations and county organizations. And that's really not acceptable. You ought to be able to be promoted across I mean, I know women who are in their 70s who are basically working at the lowest pay scale within their organizations, doing tremendous work, saving lives every day, working tremendous hours. I mean, we all know what community health workers do in response to their communities. So I think for us, it was just, how do you promote the workforce as a whole? And it was really community health workers who decided that they wanted to work towards voluntary certification. And they really felt that a lot of that was recognition for what they do as a workforce, and recognition from the profession, but recognition from the state. And so that was a lot of the choice of our process, was just, there's a lot of roads we could take. We could do a certification that's not legislated. We understood that probably we would not get access reimbursement that way. So that led to a lot of the decision to do access reimbursement, but it was like a 4-year road and a whole other process. Really working with community health representatives was huge, really unifying the workforce across the state. And I encourage, all of us here today to make sure that the community health workers who are working in our programs have the opportunity for professional advancement, and working with community health workers with their professional organizations, and thinking about advocacy on a professional level, because in a unified way, they decided that that was the best approach. And CHRs are in a completely different funding stream. They actually are funded by the Indian Health Service for the services that they do, but that doesn't mean that they get the training they want or the recognition they want. So, I mean, it's hard, Marjorie, to answer that quickly. We've written some articles about it. I know other efforts out of Massachusetts have had similar approaches, but mostly I just say, make sure that the workforce is coming together and deciding what they want to do. It was never our decision around a specific program, but really how, and the long game is to continue to just put the workforce front and center and making all of those decisions. And the Arizona Community Health Worker Association will be the organization that takes that forward.
Thank you so much. It sounds like, Maia, what you're saying is that it has to be a movement, that the CHWs have to be front and center, and creating the advocacy force behind the work, and ensuring that there's a unifying group who can push that conversation forward is really important. So thank you for that, Maia. Sarah, I would love to hear more about your funding mechanism, what the future holds for sustainability for the work that you're doing, and any lessons that you and your colleagues have learned in Baltimore.
Sure. Yeah, so for us, the primary funding for the Baltimore Health Corps is philanthropic partners and CARES Act funding. So both of those are, as you know, kind of set in advance. So we know that the immediate Baltimore Health Corps work is relatively temporary in nature. However, we continue to explore, what this looks like longer term. As you know, it's set up for pandemic response. So the immediate needs were kind of the emphasis and focus for now, but the team continues to kind of think about what that looks like longer term, as well as how we can use this work to elevate community health workers and explore other opportunities for funding. In Maryland, community health worker certification is relatively new and has had a lot of effort and kind of focus on it right now. So I'm sure it will be continued as the project evolves and the needs of the pandemic evolve as well. Like Jenna said, I wish I had a magical answer, but that is kind of how our project is functioning right now.
Great, thank you. And so because we don't have a magical wand, if we can talk for the last 4 minutes, it's the last 4 minutes in which the moderator asks the questions. I hope that the audience has been typing in questions in the Q&A box that I'll ask either Dina or Amy to read for me, since I no longer have internet access. Sorry about that, I'm out of the country. What do you think the role of public institutions should be? What role should they be playing in developing and funding CHW programs in general? Public institutions like at the state, local, and federal level. I'm going to start in the reverse order this time. So please, if you would go first for me, Sarah, and then Jenna, and we'll save for.
I think I should actually probably defer to Maia and Jenna on this one. I would have to say I'm not an expert in this particular area, so I'll yield my time to them.
Okay, thank you, Sarah. Jenna?
Sure. Yeah, it's a great question. So I will say that I spent about, I think Maia, you alluded to this, I spent about 3.5 years debating this in Connecticut about what the role of the state should be. I'll be totally honest, I don't have a solid, I can be swayed either way. What I would actually prefer to see though, is rather than the states try to take this on, I would like to see something done nationally. And I think that the challenge with doing it at the state level is that you have these sort of, I mean, when we tried to do this in Connecticut, when we tried to establish certification in Connecticut, we reviewed every other state. We talked to as many states as we could that were entertaining this. And it was just such a range of how states were thinking about this, like what were the requirements, and was it voluntary, was it required, and it was just such a, in my opinion, such a mess. And I think that having more of a national push for this would, and I know there are national efforts to do things like this. I think it would do a few things. One, it would, we could actually solidify some basic requirements, you know, for if we were talking about certification, some basic requirements for community health workers, some basic skill sets. I know a lot of work has been done in this area, but to really codify it would be remarkable. It would potentially have some benefits for funding if it could get baked into Medicare first. That would be phenomenal. And I also think from more of a like career standpoint, having something to hold on to that is national as a career, so to be able to say you're part of a national organization, I think would really go a long way to strengthening what has been happening in this country for a long time. I mean, community health workers are not a new idea. So yeah, I think it really at this point, I would like to see something happen national as opposed to the state level.
Okay, well, you heard it here first, ladies and gentlemen. Not the national movement, as Jenna mentioned, community health workers have been advocating and have been organizing for several decades now. But this idea that we just make it a national movement and require the legislation or the work be put in now could be something that maybe this new administration would be willing to take on. Thank you so much, Jenna. So Maia, we said let's even Sarah was like, yes, I'm giving Maia my extra few minutes, and we'd really love to hear your perspective on what role the local, state, and federal government should be playing in the development of CHW initiatives and in the funding of them.
Well, I mean, I completely agree with Jenna in terms of a national profile, and I think Carl just put in the chat about the National Association of Community Health Workers. And I would say, in addition to that, the project that Carl, others worked on, the C3 core competencies, in which they developed the core competencies for the profession. I mean, they had a core, but they went through and vetted them with state associations across the country to get input. That's what we used. We used all of those tools to work on a state level. So, I mean, I think the more that community health workers can talk to each other across the country, the better. I think the logistics of health financing, when you get down into the weeds of that, there are some things that you just can't do. Like every nurse, if you want to get reimbursement, you have to have state things as well as federal things. So really kind of teasing that apart And for some states, reimbursement in that manner isn't the best way to make sure that community health workers are driving their professions. And I think that's where, in Arizona, it's an anti-regulatory state. It was very hard to pass this legislation. It was somewhat of a miracle. And it had to do, I think, with the fact that CHWs made such a good argument for themselves. And so I think that being able, and the fact that we had a lot of Arizona generated evidence from all of the partnerships and evaluations and stuff that we've done in our very close collaboration with the Arizona Department of Health Services. And I guess that's another thing that I would say, that even if you're looking nationally, creating those partnerships with health departments is of key importance. In New Mexico and Texas, those relationships have been very strong. New Mexico funded certification through their state health department, and that might be much harder to make that happen on a federal level. So I think you do whatever whatever you can do in the moment to further your goals, and that each state offers different opportunities. I think in some ways in New York and Connecticut and Pennsylvania, there's just been a lot more flexibility in the systems, and there's been a great innovation in terms of really moving things across health systems, which is very impressive. So I think we learn from all of those local efforts the way that we do in our United States, and we also try to get some support financially on a national level. And I certainly encourage the national efforts that Jenna talked about.
Thank you so much, Maia. And now is the time that our audience can be putting in their questions in the Q&A. There may already be some questions there. And so I will ask one of our colleagues to please ask the questions of our panelists so that we can answer the things that our audience has, the questions that our audience have for our panelists, please.
Sure thing. Thank you so much, Marjorie. And I love how we're just figuring out how to make the technology work. We have a lot of people here busy on the back end. So one question that came in for Jenna is, you talked about paying attention to ROI and how that's important. So are you also measuring SROI, which I assume means social needs related ROI, especially for social determinants of health and improving health equity? And if not, are you measuring social determinants of health and health equity and keeping track of that in any way?
Yeah, that's a great question. So at this point, we don't have a solid plan for doing so, because right now we're highly focused on measuring ROI. And to be transparent, we had plans to do this right about in mid-March. So as you can imagine, we've been a little bit delayed on all of this with our data analysts. It's a little tied up with COVID. So that is our first and foremost, our goal is to make sure we can do a comparison analysis for ROI, really related to acute care utilization. But secondarily, I would love to do an SROI analysis, and we certainly have the data to be able to do so. And we continue to gather more. So, so that's a great, I appreciate the question, because I would love to be able to do that when we have our data analysts freed up.
Can you say just a little bit more about what kind of social determinants of health or social needs indicators you're looking at?
Yeah, so I mean, in terms of what the data that we have, most of what we have is directly from our electronic health record, our CHWs, documenting the needs that our patients have identified through their self-determined goals. So we would want to look at those compared to zip code, language, insurance. In our system, we focus a lot on housing stability and immigration status because of our patient population. So we would love to sort of dig into that a little bit and better understand the neighborhoods. And we'd also, I mean, it would be wonderful if we could do more of that related to what's been happening for the past 7 months. That might be a little trickier because I didn't really talk about this in the presentation, but we've really shifted our focus over the past 7 months. So we haven't been doing our typical intervention, but we have been continuing to work with patients. So I would love to be able to dig into that a little bit more and understand, what's been happening over the past 7 months and how we can adapt our intervention going forward.
Great, thank you. One question that is for all of the panelists is about engaging with payers, and hearing over the past couple of panelists that it's it can be laborious. You have to get everybody lined up early and continually sort of refresh those relationships. Can any or all of you speak to how your programs have or haven't engaged with payers, and what your success has been and any lessons learned from that?
Sarah, did you want to say something?
I could just say that we have not yet engaged payers. Because we just started, most of our community health workers have recently started. So I think our hope is to have them get in their roles a little bit more, and then be able to show kind of what's happened thus far, and then maybe circle back on some of those conversations. So unfortunately, I can't speak too much to this question.
I think the only reason the legislation passed in Arizona were the payers. Once we got Banner Health, which is the biggest payer healthcare provider, and the Arizona Association of the Arizona Alliance of Healthcare Plans, which is the major Medicare provider, insurance provider to all of the, I still don't understand the system and who's called what. But once they got on board, things really changed, and those people have incredible power. So I think, again, just the grassroots movement and really being very clear over time about what our goals were and being able to communicate those with the payers was important. And yes, I mean, depending on what you're looking for, having the support can make a huge difference.
Yeah, I'll just add that in my current program, we have not really gotten to that point yet, having the discussion with the payers. In my previous work in Connecticut, I would say one of the biggest considerations for why why we pursued certification was because the payer said, we really can't go much further without certification. And so that's really why we did it. But I'll caution, and I'm sure Maia's extremely familiar with this, I'll just caution with the fact that I know some states have struggled with that because they have gotten to the point where they have an agreement with the payers, and they really box in what the community health workers are able to do with patients because of the limitations of the agreement. So it's definitely difficult to balance those two, which is why, going back to sort of my comments on the national piece, definitely difficult to do, but maybe more helpful than working with individual payers and potentially boxing your CHWs in. So.
Great, thank you. I was wondering if we could go back to, I don't know if you were all able to listen in on the previous panels, but there's clearly a need to sort of change some of the narrative around the value of community health workers, the workforce, and what they do. In addition to, I think, this national policy work, but where could we be impactful, do you think, in trying to broaden the discussion of what value means in terms of the community health worker workforce?
I can just speak to a little bit of this, I guess, for our particular project. Because our community health workers are serving in such vital roles for the pandemic response, for care coordination and contact tracing, I think there's a large narrative to tell there about the extreme value of community health workers and how they've played such an important role in the pandemic. So more to come on that, like the previous question as well, but I think there's a lot to say.
Well, I've been doing research, community-based research for in my ripe old age of 56. And I guess, I just get fed up with how we measure progress, and the fact that we're looking at health outcomes and we measure in these ways when You know, I think that that's where I'd get out of the box is that, you know, what is it? I think we're not really measuring a lot of the impact in terms of long-term, you know, what's the impact of a policy over the long term? We just don't really know how to measure those things very well. And so we don't. We look at 6 months of healthcare, of health outcomes, and we don't even know what's happening 1 year, 2 years down the road. And so there's things that really look at snippets of interaction. I like all these ideas. I mean, Jenna, the idea that you'd have a program that was in place that could be available to people over the long term, that's a healthcare worker, and that's huge. And I think that some FQHCs are doing that already. They have community health workers in place that are there over the long term and have relationships with patients and can have a huge impact over time. But as long as, I mean, research is focused on these kind of outcomes in order to get funded, it's very problematic. And so finding maybe innovative funders that are willing to look at different ways to measure things. I know there's efforts of the Common Indicators Project with Noelle Wiggins and her group to look at different ways of measuring impact and things like that. So I think that would be one way of maybe, from a research perspective, moving the needle.
Yeah, no, I totally agree with Maya. I think the short-term view of research is just, it's really hurting us, and being able to look further out and coming up with some innovative approaches is like key to I think the big picture. And then I think on a smaller scale, just like thinking about our own system, educating, I feel like we've been talking about this for a long time, and I guess in my mind personally, I thought we were further ahead on this, but I really found that we aren't, is that educating our care teams within the hospitals about community health workers and really helping them understand the value, is that work is not even close to done. And I think if you can make a community health worker vital to the care team, then when you go to take them away, then you have this automatic advocacy group, which is your care team, that says like, well, we can't lose that person. And so that work is just as critical and sort of complementary to the actual research component.
That's great. Somebody actually asked a question, Jenna, about how you share your metrics with the care team. You know, do you do that on a regular basis? And you know, how do you handle the communication without overwhelming people with data?
Yeah, it's a great question. So we share some very key metrics on a weekly basis with a select group of care team members that we work closely with. So that's, and then you know, I say regularly, but to be transparent, our program started last August and then pretty much got, you know, paused to some degree in March. So it wasn't a terribly long time, but you know, we're very communicative with all the different care team members across the hospitals. So we did a variety of presentations and things to bring other groups in, and those who were more interested, we would engage further. And then in terms of just like regular tracking, as I mentioned, because we're lucky enough to document in the health record, the sort of patient-specific information can be found by any care team member that's in the chart, which is super helpful.
Great, thank you. Let's see, there was a question. I think you covered this in the Q&A, Sarah, but in case people didn't see it, could you let us know a little bit about the long-term employment strategy for your community health workers?
Sure. So for us, it's not just about community health worker opportunities after these temporary roles are complete. For some people, you know, maybe they are pursuing a community health worker position, but for others, their career navigator will work with them on kind of an assessment of their skills, what types of things they're interested in after this role concludes, and how this opportunity, as well as the any other professional development may help set them up for future in those roles. And so we hope that the skills and experience that they're gaining from the Health Corps is helping to set them up either for another public health opportunity or for another role that they might be interested in, because many of the skills, as you know, are transferable to other opportunities.
Great, thank you. And Maya, similarly, you had an exchange with someone in the Q&A about the difference between the CHWs who work in the clinical and community settings and how they actually work together, and what their day-to-day looks like. I know that's a loaded question, but maybe you could give us a little taste of what that is.
Yeah, well, I just think it depends on the organization you work for. But in general, clinics tend to be driven very much by time and by role, right? So people have specific roles and they're confined within those roles of what they're able to do, and then they have certain time they're allowed to do it in. And so an FQHC, or a federally qualified health center, that creates a really flexible place for a community health center within that, for community health worker within that system, that's great. But I don't think you can take it for granted. So in general, when that community health worker is able to work with a community health worker in the community to sort of say, well, I'm getting these social determinant needs, or this person, I just think they could benefit from talking to you. I think within a community setting, there's a lot more flexibility to sort of figure out what needs to happen. I can listen to you we were just talking about this the other day with one of the people that was working on the model, and she said, well, how long do you talk with somebody? And she said, well, I usually, I schedule 2 hours, and sometimes it takes a little less and sometimes it takes more. So, I mean, how sustainable is that? I'm not sure, but on the other hand, I mean, that she was available to do whatever needs to happen, which I think in the clinical setting, that's just a lot harder. So then also, I think community settings are much more comfortable and they have much more capable in working on community advocacy. And I think community health workers have a huge role to play in advocating for communities and policy change and those other things. They are representatives of community. They understand the problems, and I think creating a role for them in policy, they have done it in many instances and many projects that we've seen in Oregon and other places. And I think the more that we can make sure they still have a role, if we just focus on those health outcomes and those clinical settings we're missing, I think it was Jenna who talked about the roots of the CHW workforce. We'll be doing a big disservice and not addressing the racial inequities that we brought up earlier. So thank you for the question. I know there's a lot of conversation about this, and I'm only one person commenting.
Thank you. And then I think we have time for a couple more questions. Jenna, somebody said that it seems like you could expand your program, and wondering how many potential patients do you think you could serve at scale, and how many CHWs would you need to do that?
Yeah, we definitely could, and it was always the intent to do so. In fact, if it not for COVID, we probably would have already this year. In our system, we have 11 acute care facilities, so we're only at 2 right now. We would like to be at all of them, and then potentially even get further down to our FQHCs. So, you know, right now we're basically serving about 60 patients a month, 60 patients for the 3-month period. So, you know, because that's how many CHWs we have. So, I mean, honestly, like the opportunities are endless, like depending on the funding, to expand, to have, you know, additional CHWs within the facilities we're in. We could definitely have more, because our hospitals serve so many patients, and then expanding across all 5 boroughs. Right now, our 2 hospitals are only in Queens, so we're only serving the 1 borough. So to expand to all 5 would be tremendous. Yeah, and it really just, you know, comes down to funding. The model itself is completely replicable, so that's not an issue.
So are you not sure in terms of operational funds how much you can scale, because it's just not clear how much the hospital is willing to expand it?
Yeah, at this point we have funding baked into our office for the program that we have. So if we wanted to go beyond that, we would need to get approval from higher leadership, and truthfully right now it's not a great time for that. So that's not to say we're not trying, we are, but it is definitely a difficult time to try to expand a program, because we're technically part of the city, for those who don't know. So, you know, our entire COVID outreach is very much, our COVID response is very much linked to the city's response. So.
Well, thank you so much. Before I offer some closing remarks, I just want to ask each of the panelists if you have any, I like the way Sana did this at the end of the previous panel, like if you what is your wish for your own programs and for the CHW workforce? What would you like to see happen in the next 2 to 5 years?
I'll kick that one off. So actually, I would love to see something like what Sarah's working on in Baltimore take hold in New York. I think it's just a fabulous approach. I absolutely love the emphasis on career navigation and like prepping individuals to go on to careers that are not necessarily community health worker or health related, because I totally agree. I think like so much of what we work on in our program, and I know in other programs, are so transferable. And I just, I want to embolden the CHW workforce as well, but I think that approach is just tremendous, and I would love to see something like that take hold in New York. So that's one of my dreams.
I guess mine is a little bit broader than just for community health workers. I would say for the public health space in general, I hope that this can be a moment where some things are reevaluated. What education requirements are needed? Where can we, push a little bit outside of the typical thinking and use this as an opportunity to really shift how we do work and who can do that work, and think more inclusively and really bring in that equity lens to more of the public health space.
Those are great responses. I feel like I'm so down in the weeds on this. It's hard for me to get the big picture sometimes, but in listening to you all, I think what I would say is I really want the community health workers that I know to have the opportunity to speak in spaces, to have the time of their positions to really speak for their communities in spaces where decisions are going to be made. They're hugely important in terms of understanding problems on the ground. So the more that we can get them involved in policymaking, as well as in the day-to-day work that they do, I think they have a tremendous amount of information and insight to offer us as a country. And so I hope we find ways to continue to elevate the profession.
That's fantastic. Thank you so much for all of your insight. And thank you, Marjorie, for moderating. This has just been really a super thought-provoking panel. So I really want to thank all of our panelists, Maia, Sarah, and Jenna, for talking with us today and sharing your wisdom. And before we go, I did just want to give a huge shout out to Dina Pimenova, who's the project coordinator for the Community Health Worker Research and Resource Center. She's been super instrumental in helping to put the summit together and keeping us all on task and making it run smoothly. And also to Harmony Arcilla, who graciously stepped in to offer a ton of logistical and technical support. So really a huge thanks and appreciation to both of you. And I don't know, I think just to wrap up, I feel like, I've been taking notes over the past, for all of the panels. And I feel like one thing that we really heard was that the CHW workforce is extremely passionate, dedicated, activated, and they inspire, they heal, they lead, they motivate, they encourage, they have faith, and they inject hope. I really loved Emilio's description earlier. And I think what, a lot of what we're talking about is an indication that we feel like they deserve better. They deserve better job security, greater acknowledgement and recognition of the value they bring to patient and client care. And, I think all of the panelists have expressed that in one way or another. And I think we have also identified some policy directions where we could work on advocating together around more sustainable payment mechanisms, working with the ones we have to make them easier to access, but also pushing for state, federal support of the community health worker workforce. With that, Nadia, do you have any closing remarks you wanted to make?
I did. I'm going to take my home court advantage and jump in for just a moment. First, to just echo Amy's thanks to this panel and to the previous panel today, as well as for yesterday. It's just been an amazing 2 days, I think, for those of us who know and love and have had the pleasure of working with CHWs and this workforce. It's this type of event comes from a very an emotional place, I think, a lot of times. And I think that a lot of that was expressed today by CHWs themselves and by all of our panelists. You know, COVID, one of the very few silver linings of a pandemic is it's made our world smaller, and it's given us this ability to connect in ways that we haven't been able to before. But you know, this type of connection is very difficult to coordinate and arrange. And so I just wanted to take a few moments to really acknowledge and highlight the individuals who played such a key role in pulling this together. In particular, Amy Freeman and Dina Pimnova. You know, they're our colleagues at NYU. Both of them have worked tirelessly to pull this together. You know, Dina's been very behind the scenes today. I don't know if you're comfortable just coming on to say hello to everybody. It's fine if not. But, you know, has really done a lion's share of that behind the scenes work that's really made this a success. And then to Amy, you know, she's been a tremendous thought leader in pulling this whole event together. Has really been strategic and thoughtful in terms of making sure we're representing the diversity of the CHW workforce. And as you can see through these last 2 days, the really huge variety in approaches that we all take to really make this model work. And that's a huge takeaway for me, is that there isn't one way to do this. It's given me a lot of hope for this workforce, that I think there are a lot of tools in our toolbox to make this a sustainable workforce. And you know, Amy really drove pulling that together. So thank you to Amy. And then to also acknowledge our other colleagues at the CHW Resource and Research Center, Sana Lim, who you heard from earlier, who helps to really support driving this workforce and is a huge supporter of our CHW workforce at NYU, and to Sue Kaplan, who leads the community service plan that really sponsors this initiative. So that's it from me. It's been a real pleasure, and you know, just again, a huge thanks for your participation and to everybody who was involved.
Thank you, Nadia, and thank you, everyone.